From 12 News, this is Newsmakers.
Welcome to Newsmakers. I'm Tim White. Ted Nesi will join me on the second half. This week, as the world feels upside down, we wanted to take a step back and assess where things stand with the coronavirus in southern New England. On the second half, Target 12 investigator Sherman will join us to walk you through some data that we hope will help you cut through the noise. But we begin with perspective from inside the hospitals with two important conversations, including an ER doctor on the front lines. But first, the president and CEO of Care New England, which owns Kent and Women and Infants Hospital, Dr. James Fanale. We talked to Dr. Fanale about what his hospitals are seeing and why frontline healthcare workers are not getting asymptomatic testing.
Again, let's start with the overall trends right now. And I'm just wondering how concerned you are about the latest upward trend of COVID-related hospitalizations. And then a step further, what stress is that having on the state's hospital systems overall?
It's a good question. We've seen more cases, hospitalized cases now than we did the spring. The difference now is a couple-fold. One is the intensity and severity of illness isn't the same as it was in the spring. We're not having a run on ventilators. The intensity of illness, the ICU is not packed full of ventilator patients. Whether this means it's a younger cohort and the nursing homes have done a good job to decrease visitation so there's less spread there, I don't know. But the severity of illness and the mortality rate's lower. So we're not overwhelmed in the ICUs or with ventilators. That's a big difference. The challenge I think the health systems are having now are twofold. One is our staff is starting to get exposed to household mates or others. So the effect on our being able to care for folks is causing some challenges. So if I have a nurse whose husband's positive, she's out of work. I have a staffing problem. The second issue is most of the hospitals are having trouble with patients that are in the hospital that don't need to be there. What do I mean by that? The nursing homes are reluctant to be able to accept discharges now. So a nursing home patient of ours, that would normally go to a nursing home may spend an extra 2 days in the hospital waiting to find a bed that will take them because of COVID. And the second thing is the behavioral health challenge. We've had many more patients sick with behavioral health issues, and the run on beds has been a challenge as well. So you have patients sitting in the hospital waiting to be discharged. If we were able to get them moved to a contracted nursing home or something else, we'd have more bed availability for our patients.
What is the bed capacity right now, specifically at Kent Hospital? I don't know if you know it or have it in front of you.
You know, normally it's around a couple hundred, okay? Then we have these surge levels. We could go up another 20 to 40 beds if we have the right staff. Everybody has different surge levels that they can go to. I think the rate limiting step for most of us are, do we have the staff to do that? Example, Butler's occupancy is usually about 160 capped max. 10 days ago, 2 weeks ago, we were at 173. We could open another unit and we had staff that could staff that because the needs are high. I mean, the opioid-related deaths, those kinds of things have gone up since the pandemic. The stress is very high. But then I get a staff member exposed, I got to close a unit. So I went from 171, went to 140 in almost 2 days because we had to close a unit, okay? And limit admissions. And the system and the state needs those beds open. So we can surge higher than usual, but it's maybe 10%.
So I think it sort of begs the question, and maybe it doesn't help based on what you said with staffing, but is it time for the state to consider putting, once again, elective surgeries and other procedures on hold if these hospitalizations continue to rise like they are right now?
Yeah, I don't think so. I firmly don't think so for a couple of reasons. One is we're able to take care of those patients safely. Again, if we can, we're all still surging and getting our beds open for patients. If we can settle the behavioral health bed issue and we can settle the nursing home issue, we don't have a problem. If we close elective surgeries, okay, first off, we know we can take care of our patients safely, and we're doing it now, and we're not having spread in our ORs. So it is safe throughout the state of Rhode Island. It is safe. I'm going to emphasize that again. If we shut down if we shut down surgery, et cetera, it's going to put your hospitals in financial peril that we may never come back again.
It's that weak.
We lost so much money last year because we didn't qualify at Care New England for a lot of the CARES Act money because I got 2 specialty hospitals. And $30 million in the hole is a big number. I don't think we will withstand another one. Okay, and I think the other hospitals be in the same jeopardy. So we have to look at the public health. Good. Let's see if we can get our patients transferred to the appropriate levels from the hospitals that will relieve the overwhelming demand at Rhode Island Hospital, Miriam, Kent, and the other hospitals in the state. I think that's a solution. Then if that doesn't work and we still haven't, we have to be ready to open up the field hospital.
As I told you before this interview, I've talked to a couple of frontline hospital workers, not in your system, that told me they have never been tested for the coronavirus. And I'll be honest with you, doctor, that surprised me. But based on what I heard from you before, that is not unusual, that doctors who are asymptomatic are not getting tested.
Don't have the ability testing wise to test asymptomatic people. As we spoke a while ago, and for your listeners, we at all the health systems are strapped with availability of testing. We have to test our patients that are symptomatic. The colleges, universities, sports teams, they're all buying testing and we're competing with them to get it. Obviously, we don't have the coffers to be able to pay extraordinary costs, right? But we fight every day to get more testing available to our patients. And we're now offering them to symptomatic patients. And we haven't been able to screen asymptomatic people, as bizarre as that may sound. And you told me the universities are testing every week, certain people, and they're spending a lot of money on the testing, and it's become the law of supply and demand. I think we have enough testing to last us a week, and we keep getting more and more. Every day we get some more. But if we had a 2 or 3 week supplies, we would expand our testing capabilities. But that to me is the one Achilles heel of this whole issue. It needed to be addressed on the federal level months and months ago, and it wasn't.
Now, Dr. Otis Warren, he's an ER doc and the head of the state's Emergency Physicians Association. I start with Dr. Warren where we left off with Dr. Fanale to understand how frontline healthcare workers feel about the lack of testing.
Why is that the case from your perspective, that frontline healthcare workers aren't getting tested at all, forget about regularly?
Yeah, it is a complicated issue, I think. I got the same sentiments when I talk to colleagues of mine, many of which point out the irony of, if you work in a big factory or if you're a college student, you're getting tested regularly for asymptomatic screening. And we go into the hospital every day and see and treat COVID patients, yet we in the hospitals are not getting screened. The caveat to this is if we get tested if we have symptoms, even the slightest symptom, we get tested. But talking to other people, and particularly, I get the reasons why this would not be done. On one hand, it is a exceedingly expensive proposition to initiate system-wide asymptomatic screening for every employee. The other problem that it gets into, that I absolutely understand the hospital administration's point, is that if you tested every healthcare employee without symptoms, you're going to get a number of asymptomatic people who test positive. And those people will then have to be out of work for 2 weeks or so. And that could really decimate the workforce of a already kind of strained system. We're facing nursing shortages across the country, but also locally, and particularly when talking about opening up the field hospitals, staffing that is going to be really difficult. And so the real concerns that I have, personally, I would love to get tested asymptomatically, but I understand, my personal needs and the needs of the healthcare system are not necessarily aligned, and the healthcare system needs employees to work.
And I get that, and that's, I talked to Dr. James Fanale, who raised that point, and another that I'm going to bring up. But, some people might hear what you're saying and go, yeah, but okay, if Dr. Smith is asymptomatic, but he's COVID positive, there's a reason they would quarantine for 2 weeks, don't we? Despite what the strain would be on the system because of staffing, don't we not want them in the hospital where they could be spreading the virus?
That's a really good point, and something that kind of we struggle with ethically, and kind of in my group of emergency physicians I talk with. I think the practical point is that I think there's very little chance that a physician who is in a mask and practicing proper PPE when they contact a patient, if that physician or nurse is COVID positive, asymptomatic COVID positive, there is a very small chance that they would transmit the virus to the patient. Now, your point's well taken. I can't say that it's a 0% chance, but we have seen very little transmission of COVID within the hospitals once the patient's already admitted to the hospital. Now, there's some exceptions to that, but the transmission in the hospitals appears to be much less than the transmissions in the community. And, we pride ourselves that the hospitals are safer than the community at this point just because of the universal mask procedures, the precautions we take every day.
I wonder if there's if you could speak to it personally. Again, I know talking to some of the ER doctors, I suspect that their big concern is they go home, and they've got spouses or they have children, and they'd like to know if they're a carrier in that moment. Just help us understand, to the folks that don't work in the medical community, the kind of stress that you feel in working in an environment that, we know is COVID positive.
Just personally, we have taken all these precautions to kind of protect our loved ones and people we live with. Every day I go into work and I see COVID patients. I look in their mouths, I touch them. Occasionally I put breathing tubes in their trachea, and I'm in close contact with it all the time. And the coming home from a hospital and re-entering your house is fraught with anxiety and fear. And personally, what I do is I take my clothes off in the garage and change out there. And when I enter the house, I immediately jump in the shower. I think every healthcare worker has their own little personal routine that they do to protect not only their family, but also their peace of mind, that they're doing everything they can. The reality is we have been, thankfully, with all of our experience, that healthcare workers, while they are at higher risk, we have not seen a massive infection rate amongst healthcare workers. And I think that is kind of the testament to how well masks particularly, but generally other protective measures work. Like I said, I look in the mouths, I touch, I listen to the lungs, and am coughed on every single day by COVID patients. And thankfully, I have not contracted COVID as far as I know. And I think that's true of every healthcare worker, every emergency doctor in the state. And I think it's a testament to just how well the protective equipment works. And I think we would be in a much bigger problem if the protective equipment did not work in the way that we are seeing it working.
When we come back, Ted Nesi and Eli Sherman join me to break down some of the data that we've been tracking here at 12 News that we hope will bring perspective to this confusing time. Stay with us. You're watching Newsmakers.
For whatever set of reasons, although we all seem to think we're following the rules, clearly we're not, because we're in a really bad place. So I have done everything that I knew how to do to avoid the severe restrictions that I'll be laying out today. And the reason for that is because I know this is going to be tough.
That was Governor Gina Raimondo at Thursday's briefing, and with all the numbers going in the wrong direction, it was a grim one. Welcome back to Newsmakers, everyone. I'm Tim White, and I'm joined by my colleague, 12 News politics editor Ted Nesi.
And we want to look at a snapshot of the restrictions the governor put in place. We'll take those in a second. You can see the three categories that the pause has from now until December 13th. Things that remain open, things that are limited, and others that are just closed. The main ones are, I would say, schools with in-person classes continuing through 8th grade, but new limits for high schools. Social gatherings will be limited to one household. There's reduced capacity for restaurants and churches and stores. And among the places being closed altogether, gyms, as you see here, and we're hearing some frustration from gyms right now about that.
Yeah, and we are joined now by our colleague Eli Sherman. Eli, I want to start with the work you've been doing on contact tracing. When the governor is making these policy decisions that Ted just outlined right there, she's looking at data from the Department of Health, which contracted with Salesforce and IBM to assist with tracing. You've been bugging the state to provide you with these numbers, and this week they released them. Summarize what you found.
Yeah, so a lot of the transmission we're seeing happening, Tim, is in the household and between family members. Like you said, we've been trying to get at this data for quite a while because people keep asking, okay, where are transmissions happening? Where is the data that supports that? We got a small tranche of data from IBM, which is doing some analytic work for the state. And it showed that 40% of all transmissions of infections that they looked at, about 4,100 infections over the last couple months, were happening in households and between family members. The other 60% were happening in different places around the community, but that whole household section was the largest. Of that 60% or so that was happening in the community, we saw about 36% happening at workplaces. So this is people who are going to work, reporting that they have been at work, and IBM has determined that transmission probably happened there. Another 26% of that community spread portion is happening in places with service industries. So that could include anywhere where there's customers, like a restaurant or bar. You've heard the governor talk a lot about that industry. And then the other portion, 11%, is happening in places like churches, parks, sports events and arenas. And so that was the gist of the data that they gave to us. I will note that absent from this was schools, any mention of schools, which of course is such a hot topic for everybody. And, I talked to some health officials about that. They acknowledge that they don't have that broken out, but they did point out that if any teachers or staff members were getting sick or were part of that sample size that the IBM was looking at, they would have been included in that workplace section, the 36%.
Well, and for folks at home, Eli threw a lot at you right there. He was sort of giving you the thumbnail of the data that he got from IBM. So I encourage you to go to WPRI.com and read his full breakdown there, Ted. And Ted, I'll tell you one thing that sort of struck me when I was reading Eli's story and doing some reporting on it this week as well, is that when cases are climbing at the rate we're seeing now, and there are so many cases out there, contact tracing in some ways is really not as valuable in terms of it's almost too much.
Yeah, no, that's what all the experts tell us, Tim. We had Eli I saw getting tweets and replies on his story from viewers who are saying, well, I haven't even heard from the contact tracers, and my friend tested positive 3 days ago. But based on the experts I've talked to and what I've read, contact tracing, it's an intensive. You think about it, it's an intensive thing. If you call Tim White, you give them a list. I was with Ted Nesi, I was with my wife and children, and they have to start going through that and making those calls. That takes time, it takes effort. When you are getting 1,000 new people to do that for a day, which is where we're headed in Rhode Island, it's very hard to keep up with that. So I think contact tracing is much more effective when you have a much more limited number of cases, like we did early, maybe during the summer when it was lower. At the pace Rhode Island is going in, that's why they're having to go to population level strategies.
Eli, we're going to go back to you here with a different chart that you've been watching on the track cases page of WPRI.com. And this chart really does not get a lot of attention normally, but is stark. and it is the new hospitalization admissions. They are soaring. As you can see, we have it on the screen, Eli, right now, that the admissions are going way up. What are you looking at when you see these numbers?
Yeah, same thing, going up. That last bar all the way to the right that you see, the last column, I should say, that was a record high, 53 admissions in a single day. And, we've never seen a level that high in any other part of this pandemic. So people should really, keep a close eye on that, because while cases is something that can fluctuate for different reasons, on the weekends we see cases dip because fewer people are getting tested. We see more robust testing strategies, more testing capacity these days, which can help fuel, to some degree, more cases. Hospitalizations is a really key indicator because that's a body that needs emergency care to some degree. And the fact that, people are coming into the hospital at such high rates right now should be something that people are aware of and keeping an eye on. You heard Dr. Fanale in the first half of the show say that they're seeing more hospitalizations right now than they ever did, which is what, that matches up to what we're seeing in the data.
And Ted, just briefly on this, as Eli said, it's a good number to track because cases can be all over the place. And it's also a good number to compare to the spring, right?
Yeah, because I checked with some of our docs in Rhode Island on this, and you got to remember, if you go back to the spring, so if we think of the spring, we were not catching nearly all the cases. There wasn't enough testing. We all remember in April you could not get a test easily. But they were testing everyone in the hospital. And so those numbers, when you look at the hospitalizations for COVID-19 in the spring and you look at them now, those are pretty comparable, I think, because they were checking who had COVID back then, and they are, of course, checking now. So that's part of why. And look, it's you don't have to be Bob Woodward to figure this out. Listen to the emergency room doctors. They say they're seeing it worse than they saw it before. And as Eli said, this admissions number is a really important one to watch, because I don't think it's going to put such pressure on the hospital system in Rhode Island, and of course anywhere else this is happening, to maintain a pace of 50-ish COVID admissions a day. Now, I assume it'll dip in the coming days, just as with cases. You see dips on the weekends. People don't come in. I talked to a hospital leader the other day who said people aren't going to want to come in on Thanksgiving, but Friday will probably be Black Friday will probably be really busy. So there are those fluctuations, but it's really important. That's part of why I should say it's really important that they get those field hospitals open, because they just are going to need more beds if admissions continue at anywhere near this pace.
Eli, we have just about 3 minutes left in the program, but I want to talk about some good news. And to my Newsmakers friends, good news is, relatively speaking, right now. Hospitalizations, as we talked about, are up, but the number of people in the ICU and on ventilators is not as high as it was in the spring. And you've been talking to some experts as to why that might be.
Yeah, that's right, Tim. ICUs have been averaging right around 20 to 25 during the second wave. And just to give people an idea, at the peak of the first wave, we were almost up to 100. So that's really quite a bit less than what we were seeing in the spring. I talked to emergency care docs as often as I can. I would say that they're not 100% certain, but there are some contributing factors. This time around, they are seeing a lot more younger people who are coming into the hospital. And as we know about this virus, younger people have better health outcomes after contracting it than older adults do. Also, they've had some treatment, some successful treatments that they're saying are working, not necessarily in getting rid of the virus, but helping people to avoid emergency or intensive care, I should say. And also, I think in the first wave of the pandemic, there was a lot of intubation, putting people on breathing machines. And I think after some time, emergency care docs determined that the care for the virus gets a lot more complicated after someone is put on a breathing machine. So they're finding some alternative approaches and methods are proving a little bit more effective, which may also be affecting the numbers.
Ted, I want to shift gears briefly here. You covered the House Finance Committee hearing this week with House Fiscal Advisor Sharon Reynolds-Ferland testifying. While the outlook for the current fiscal year isn't quite as grim as maybe many predicted, there are warning signs for fiscal year 2022, which, by the way, the governor has to take care of in January.
Yeah, it's like a multi-car pileup of budgets here, right? Because the last budget, you could still get some extra federal money at the last minute that changes the old budget. The current year budget, they haven't finished yet, and we think they're going to come back, as Joe Shikarchi said on the show early last week, in early December on that. That budget, they now think, is about $275 million in the red. Way better. And we
than $900 million.
Than $900 million.
Yeah.
We were talking about that a couple weeks ago on the show. But then, as you said, in January, the governor needs to put in her budget for next year. That's the fiscal year that starts July 1st of 2021. That House Finance Chairman Marvin Abney said is his real concern, because there is, as everyone knows, a lot of federal money has come in to help with COVID costs. The $600 and the stimulus payments, which were those created economic activity that helped with tax receipts. There's a lot of concern that next year you'll still have a lot of the negatives of the COVID crisis without necessarily some of the things that are helping to offset it in the current fiscal year. So I think it's going to be a challenging set of months, and I think, I'd urge taxpayers to pay attention, because I think a lot of big decisions are going to have to be made.
All right, Ted Nesi, thank you so much for that, and I thank our colleague Eli Sherman for his input. I cannot stress this enough. Bookmark the Track Cases page on WPRI.com. Keep watch on those, as we do here at 12 News. Thank you for watching. For Ted Nesi, I'm Tim White. We'll see you next week on Newsmakers.